Thanks everybody for joining us. This is the Heart Trending monthly webinar. This is to talk about the new development as well as new discussions with leaders in the field in interventional cardiology, structural heart, as well as heart failure management and imaging. I'm really privileged to be with my friend, Jonathan Schwartz. He is, I think we're classmates from interventional cardiology training, but definitely he's a dear and near friend. We have been seeing him at multiple conferences, a rising star. Currently, he is a medical director of interventional cardiology at the Sanger Heart and Vascular Institute in Atrium Health in Charlotte, North Carolina. He's a structural interventionalist and clinical assistant professor at Wake Forest University School of Medicine in Charlotte. He did the biomedical engineering at Northwestern, cardiology and interventional cardiology training at Stanford, and fellowship at Stanford, or Biodesign Innovation Fellow, and advanced structural congenital intervention training at Minneapolis Heart Institute. And I think that was with Paul Saraja. He's expert in minimally invasive structural heart interventions, device development, and innovation. His research focus has been a site PI for multiple clinical trials. And he's a procedural proctor and advisory board member for medical device companies. With no further ado, Jonathan, it's really a pleasure to have you tonight. And this kind of hopefully spring night in Michigan. I think warmer in Charlotte where you are.
Yeah, it's a pleasure to be here. An honor. I know we've had a lot of discussions over the years, and it just keeps getting bigger and bigger. So, congrats to you with your show.
Thank you, thank you. So, Jonathan, the main focus today is the agenda is, as you know from the title and for the audience, is to focus on the tricuspid. Jonathan, can you hear me?
Oh yeah, sorry, it froze when you were asking the question. Sorry about that.
I'm sorry. I was saying let's start with that. Historically, what was the previous management for tricuspid regurgitation before all this development lately?
Yeah, so up until maybe 4 or 5 years ago, it really was. I mean, they always call it the forgotten valve. It's almost. I give a talk where I kind of refer to it more as the neglected valve. I think we've all known it's been a problem for a long time, but we just kind of didn't deal with it. The only option really was open surgery, and there's a lot of complexities with the right heart, and the patients didn't really do that well, and so it was limited primarily to like congenital cases or concomitant surgeries, or if there's an infection risk or some endocarditis. That a lot of patients weren't getting therapy, and really the mainstay of medical treatment was just diuretics, which patients don't love, and you're sort of just treating the side effects, obviously. And so there was a huge need there, and it has led to a multitude of different devices. And sort of along the way, which I think we'll talk about a little bit later, we've had to adjust how we look at the valve, because it is a lot more complex to view it and to plan than for sure the aortic valve, but also the mitral valve.
Right. So you're touching on a very important topic. So what is the current guidelines up to right now for the management for tricuspid valve?
Yeah, so they haven't been updated yet, despite all the transcatheter therapies. I'm sure it's coming, but right now it's really medical management and then consider surgery for select cases. So we're not at the point where that's been updated, but I think most people are aware now of the transcatheter therapies, and I think more and more we're getting a lot more referrals to consider these. I would say the patients that screen fail for the devices, which we can go through reasons why later in this talk, but often they just end up staying on medical therapy. I don't see a huge increase in the surgeries that patients are going for, but maybe a little bit.
Right. Yeah. So just for the audience, I think medical student, resident, and fellows is, as Dr. Jonathan mentioned, is the indication right now is if you're going to do CABG, if you're going to do a valve, then you fix a tricuspid, but there is no indication for just to go for sternotomy to just to fix a tricuspid valve as of now. Yeah. So I think there was a lot of research and focus on the aortic valve since early 2000, and then over time mitral valve. So why now tricuspid? Why the tricuspid wasn't an attention even before in previous trials?
Yeah, I think we sort of thought that, I mean, even though there were trials that showed patients with more than moderate tricuspid regurgitation had much worse outcomes than those that didn't. It was thought that it was just tolerated. And I think a large part of that was probably induced by pacemakers and ICDs and other implantable electronic devices that often will prop open the valve. Patients would live for sometimes decades with these devices and some amount of TR that was tolerated relatively well. And so I think it's sort of just extrapolation from that. We sort of didn't focus quite as much on it. But now with the rise of other transcatheter interventions on the other valves, as you mentioned, there's a lot of corollaries with the mitral and the tricuspid valve. And so there was a lot of overlap with the device design. And again, sort of how this all started was people started using the MitraClip off-label in the tricuspid position. And we were seeing that patients actually did a lot better, at least anecdotally, when the valve was intervened on and we weren't leaving this regurgitation behind. We can get into trial results, and there's a little bit of a hot topic there about outcomes, but that's sort of how we got to where we are, I think.
So over time, I mean, as you touched on something I think would take us to the next point is in terms of imaging the tricuspid valve. And this is kind of is very challenging. So why is challenging to image the tricuspid valve?
Yeah, I think the way that the heart's positioned, it makes for difficult images. We're primarily echo based in the valve world, and so while you can see, whether it's sort of somewhat quantifiable on a transthoracic echo how much TR there is, particularly like in 4-chamber views. You can't get details about leaflet lengths and grasping zones and valve areas with the transthoracic. So you definitely need a transesophageal echo to get that. But even then, it's such an anterior structure that it sits pretty far from the esophagus. And so between that and angulation of the heart, you're often fighting with putting a lot of angles on your TE probe while it's in the esophagus. The transgastric view is very important for tricuspid work, and oftentimes you're limited by that with trying to pass the probe in and out of the GE junction, or if there's GI bleed concerns, people don't like to mess around in the stomach for too long. So it makes it really difficult from traditional imaging standards, which has up to date been transesophageal and transthoracic echo imaging.
No, definitely. I mean, and it requires some skill set as well as maybe people with high volume and centers. And usually what we do tricuspid imaging is to roll in and roll out any vegetation, and usually either open or torrential tricuspid regurg, but doesn't say exactly the mechanism of failure. So let's move on to the next topic, which is etiology of tricuspid failure. Can we just go over the main domain that caused the tricuspid to fail?
Yeah, so by and large, a lot of the patients we see are lead induced. And so it's, most of the time that by the time we get to the patients, the devices have been in there for quite a while. And so the leaflet's been propped open. In general, EPs, when they're placing electronic devices, they're not paying a lot of attention to where the leads are going, or either that, or they're limited in where the device is going, particularly now with like His bundle pacing. The device kind of has to go where it is. Leadless devices are available now, but they're somewhat limited in their rollout, and it's been sort of definitely not the primary, even still, device that's chosen. But it's becoming more popular. But a lot of the TR that we see is induced by leads. Even after the leads are extracted, if the leaflets have been propped open for a while, they tend to be kind of stuck there, and so it's not something that just taking the lead out is going to fix, unfortunately. So that's the biggest one. Primary TR is pretty rare. You will see it often. I'd say the most common way that we see that is like post-transplant patients that have gone for biopsies. And then the biopsy has unfortunately grabbed like a portion of the papillary muscle or the cords, and it leads to a flail position. I'd say, that I see maybe a handful of patients like that a year. So in general, it's mostly secondary TR associated with heart failure or pulmonary hypertension or whatever it may be, annular expansion, sometimes atrial functional, but leaflet gap because of dilation of the RV annulus, or the tricuspid annulus, tends to be most of the patients we see with TR.
Great. You mentioned something about that EP or the lead-induced tricuspid regurg. Can you elaborate more on it? Especially, I see lately there is a lot of focus on it from imaging perspective, especially for transcatheter therapies, and how we can prevent this from happening.
Yeah, so this is a very interesting topic. There's a lot, if you go to, there aren't a whole lot of EPs that are talking about this, but the ones that are, they actually have some interesting data that I think most interventionalists and general cardiologists aren't aware of. But they really downplay the risks of lead extraction. And so I think in general, interventionalists have been a little bit hesitant to refer for that, because we think of, taking out a lead that's been in there for a long time is pretty high risk. But if you actually dig into the data, there are some interesting studies there. And I do have a talk on this that I can address at some point later if we want to. But the leads are important because they, number one, lead to a lot of shadowing. And so trying to see exactly where you can potentially grasp, and just some of the other details that we need, like valve area and leaflet length and coaptation gap, oftentimes it's shadowed on the echo, so you can't see it. Usually with CT scans, you can get around sort of the artifacts that the leads cause, but we are a very, I would say, excited institution for lead extractions. We have a very aggressive program, and so we've tended to do that first for patients where a lead is either causing an imaging problem or if it's in the grasping zone, if we're thinking about a clip. There are many, many cases that have been done with like the Evoke transcatheter valve where you simply just put the valve in and jail the lead. There's some concern there that, I think device disruption is pretty uncommon. Usually these leads have enough slack in them that you can get by with putting a valve inside and it's not going to affect the lead too much, or they're already in the commissural area and so they don't really move a whole lot. The downside, or what sometimes you hear about, is, well, maybe there's a concern about infection, and what do you do if you have to extract it? Sort of the counter to that is, it's not like it's just the lead that gets infected in that case. You'd have to take the valve out too. So we're kind of figuring this out. I do think it's somewhat institutionally based in whether you have skilled extraction providers, but it tends to seem like the field is going to be headed in an extraction direction, not only for assisting with getting the devices in, but also to improve the imaging of the procedure itself.
Yeah. So what is that term called, Jonathan, when you say that lead-induced tricuspid regurg?
So I don't know if it has a specific term. I guess you could kind of call it primary, but we just say lead-induced TR.
Lead-induced, okay. No. So now, like we have to, there's a problem induced by the lead. Is there like an effort to educate our EP colleagues, like to pass the wire in a certain way? Because I never seen this coming or seen presented in anywhere.
Yeah.
To avoid future damage.
Very good question. It hasn't made it into guidelines or anything like that yet. I do think probably the institutions where they have an aggressive tricuspid intervention program, most likely the EPs are, at least if nothing else, more aware of it. I do think maybe not necessarily just because of TR reasons, but leadless devices are becoming a lot more popular. And that's mostly been driven by battery life and now being able to do like dual chamber devices that talk to each other. So I don't know if that's sort of the future of EP, but I do think there is more attention there going to where the leads are placed. That said, sort of like we mentioned earlier, there are cases where the lead sort of has to be where it's going to be. And if that means TR, then potentially it means that you'll just have to deal with it. But in general, I think there is a focus on trying to minimize it upfront.
Yeah. Now let's move on to say, when did we start looking into the transcatheter options for these patients?
Yeah, so the first, I think, devices that were used were the off-label MitraClip in the tricuspid position, and it often was done, we call it sort of like a drive-by procedure, where the patient was there for a transcatheter mitral edge-to-edge repair, but they ended up getting both the transcatheter mitral and a tricuspid intervention. And that's sort of the reason for that was when you're doing a MitraClip, you actually are able to get two devices for the same cost. And so it wasn't adding any cost to the procedure just to do these drive-bys. But there's a lot of this debate about whether that's the best way to do this. In general, I don't think that's how you should do it. The tricuspid valve tends to be a bit more adaptable. And so like I've seen cases of severe TR go down to mild simply with diuresis. So there's a good chance that intervening on concomitant valve disease may lead to an improvement of the transcatheter of the TR, which then you wouldn't have to intervene on. But that said, there also were standalone off-label MitraClip interventions on the tricuspid valve, and that was probably back, the first one I want to say was maybe 2014, 15, somewhere in there. The very first dedicated transcatheter TriClip device was done in 2017.
Oh, 17, great. So it's from 17 till the Triluminate trial, like there was continuous studies happening, or there was a gap and then that trial came up?
Yeah, so there were some registry and retrospective studies. There were some sort of combos where they looked at sort of retrospective data and they do a little bit of prospective looking at the outcomes of these patients, but none of them were randomized until the Triluminate study.
Oh, okay. And so let's go to the options for tricuspid valve now, before we go to the science or the trial that is kind of presented recently. Was there like a multiple iteration of different devices, or from your experience, okay, if it works on the mitral, let's try it on the tricuspid and see what happens?
So I lost the last half of that, but I think I got most of it. Right now, we're pretty much on first generation devices for tricuspid dedicated specific things. The TriClip device is technically like a fourth generation clip device. But the clips themselves that we put in the mitral valve are the exact same ones that we use in the tricuspid space. The difference is the delivery system. There's a couple knobs that help you navigate a little bit better in the tricuspid space, and then also the curve is a little bit different. That said, the next generation device, the Gen 5 system, is going to be agnostic. So you can use the same delivery system for mitral or tricuspid, and again, the clips are the same. That should be out later this year from Abbott. The Evoke device actually started as a mitral valve specific device, and again, it was modified a bit to deliver it to the tricuspid space, and now obviously it's been approved for that first. That's sort of an interesting discussion in and of itself, but the tricuspid valve has been a little bit easier to navigate than the mitral space, and that's why it's sort of leapfrogged the mitral valves.
Yeah. So mitral is 2 leaflets, so it's usually grab 2 and then you have results. So what is the thought process, and which kind of leaflet you should grip in order to achieve the result that you're looking for?
Yeah, good question. So the tricuspid valve is a lot less standardized than the mitral valve. So we call it a tricuspid valve, but there's some valves where, again, you can debate if things are clefts or whatever you want to call the anatomy, but potentially you could say maybe there's up to actually 6 leaflets sometimes on these tricuspid valves. In general, though, we sort of group them into a septal leaflet, an anterior leaflet, and a posterior leaflet. And most of the cases, I guess, in general, as a rule, you're almost always clipping something to the septal leaflet. The clips that are just done on the anterior and the posterior leaflets don't tend to be as effective because there's not really that anchor there that kind of keeps everything in place. And so I think the majority of cases in the Triluminate study had an anterior septal location. Somewhat close behind was posterior septal. Very rarely are there any isolated anterior-posterior clips, but they do happen in cases where you've already put a clip on in the AP or in the anteroseptal or the posteroseptal location. Also, we do tend to use more clips than we do in the mitral space. The tricuspid valve is much larger than the mitral valve in general. And so I'd say most cases you end up doing 2 clips for a tricuspid.
Okay. So we know that from the recent trials, there is an improvement in symptoms. So can you walk us through the trial, quickly design, and then we had you before in different interviews, Jonathan, and you did a phenomenal job, and because you were part of the trial itself. But just quickly to what are the inclusion criteria and what is the main finding?
Yeah, so for the original TriLuminate study that was published about a little over a year ago, patients were randomized 1-to-1 for actually, well, it's a little complicated, but basically intervention arm which was a TriClip device, and then medical therapy as dictated by a heart failure specialist, primarily consisting of maxing out diuretic therapy. And patients would get a right heart cath. The main inclusion and exclusion criteria were anatomy that was amenable to clip, and so that would mean primarily, number one, can you see the valve? If you can't see it, obviously you're not going to get a good clip result. So being able to visualize the leaflets, and in the grasping zone, getting the leaflets to fall into the arms of the clip. Also, we don't want patients that had severe pulmonary hypertension. So if their pulmonary pressures were greater than 70, those patients were excluded. Right heart function, it was, that's a little bit hard to quantify. And there was an imaging sub-study within TriLuminate that looked at that a little bit, but and we can also talk about that later, but that's sort of a good marker of the benefit patients will get from it is largely determined by their right heart function. And then patients enrolled, randomized, controlled, and then at 1 year, anyone that it was in the control arm was allowed to cross over into the device intervention. We just had those results presented at ACC in the 2-year data, so we can kind of talk about that as well. But the 1-year data then also had an arm of patients where we thought you may not be able to get down to a 2-grade or less reduction in regurgitation. So for people that may not be aware, we've added 2 categories of regurgitation for tricuspid. So there's mild, moderate, severe, and then massive and torrential. And the reason that we had to add those were patients were getting clips placed, and on the old criteria, they would only go from severe to still severe, which sort of doesn't make sense, but they would get benefit from that. And so we've added these other categories. So what we used to call severe, you now make called torrential. Putting a clip on will get you to severe. Even just a 1-grade reduction does show an improvement in quality of life. So that we've learned a lot as we've done this. We've had to sort of adjust the standards that we've used forever. But there was an arm in the TriLuminate study that looked at patients that we thought would not be able to get down to a 2-grade reduction. And like I said, even those patients did show an improvement in quality of life with the TriClip over the control medical therapy arm. And same thing with the patients that were in the standard arm of the trial. The main benefit was an improvement of quality of life. Lots of controversy about that, which we can talk about a bit, but I think the negative, or the things that you could say about the trial that were maybe some of the naysayers brought up were, well, we expected maybe a little bit better, particularly with the COAPT trial as a comparison. So the MitraClip device in secondary MR had amazing success with both improvement in survival and heart failure hospitalization. And we didn't see that in the initial TriLuminate study. But with the 2-year results now that just came out, there is a demonstrable decrease in heart failure hospitalization for patients that had the clip device versus the medical therapy arm. And that included the patients that were in the crossover arm. So they were on medical therapy up until the 1-year point. They then got the device. Those patients also showed quality of life improvement and heart failure hospitalization reduction.
So when you say medical management, Jonathan, is it like you treat the RV failure similar to the LV failure, or these patients already have LV failure sorry, it doesn't have LV failure, and we're talking about diuretics.
It's primarily diuretics. You do still use pretty much all the same medications, afterload reduction, beta blockade, ACE inhibitor, ARBs, all of those tend to be used as well, but it's most of the symptomatic benefit in TR is from diuresis therapy.
Okay. And was any of these patients, and because we see them sometimes coming to the hospital as liver failure, congestion, are these patients are candidate for such therapy for congestive hepatopathy?
Yeah, so that's sort of an interesting thing that we found is a lot of that, what was being called cirrhosis and maybe thought to be a primary liver problem does get a bit better with tricuspid intervention. And so a lot of it's just the congestion from the TR. So the cirrhotics, I say, maybe, you have to be a little more thoughtful with those types of patients, especially if this is a primarily quality of life improvement thing, but, with some heart failure hospitalization now improvement. But in general, as with any procedure, you want to make sure that the baseline quality of life is someone that will get some benefit from this.
Yeah. And let's talk a little bit about pulmonary hypertension. Is the presence or absence of pulmonary hypertension will make any change in the indication for transcatheter therapy for tricuspid valve?
Yeah, so oftentimes, I would say, most of the patients we see where we're evaluating for tricuspid intervention, if they do have pulmonary hypertension, it tends to be driven by left-sided heart failure. The PH patients, chronic thromboembolics and all those patients like that, those tend to get better with focusing on the PH as opposed to the TR. The TR is just kind of a bystander. That said, they're not necessarily excluded from consideration of therapy. I think if you do have pulmonary pressures 70 or above, we don't have great data on that with regard to TR interventions. And so involving a PH specialist, I think, is key to managing these patients. And if they think that the TR is contributing to their symptoms, then it is worthwhile to at least evaluate for potential intervention.
Okay. So you suggest, do you treat the pulmonary hypertension first and then treat the valve, or vice versa? Just one more time, because sometimes you get these cases where you have pulmonary hypertension, mean is like 45, and then wide open, completely core pulmonary RV, and then severe TR, so secondary to dilated RV. I just want to know, what is your approach to these cases, and if there's any harm if you clip or minimize the tricuspid valve regurgitation?
Good question. I'd say it's hard to standardize the answer to that. I think you really need to sort of tailor it to your patient, and sort of, if you can kind of dig in a little bit and maybe do a little, all these patients will get a right heart cath beforehand in a separate setting. And so that sort of helps with the decision making. The heart team approach, as we've sort of learned from TAVR, is invaluable in this world. And so we have a very low threshold to at least have them evaluated by a PH specialist before we just go off and start clipping people. And they tend to guide whether they think, is it appropriate to go ahead and clip them? Can we do it concomitantly? Maybe they can start, whatever medications they want while we do the clip as well. Do we need to give it 3 months? And so I'd recommend just doing the heart team approach and sort of listening to your specialists.
Great. So who will not benefit? So you mentioned about the heart team. Before I go there, you mentioned the heart team when the patient comes to. So who should be referred to structural heart team for tricuspid valve? Yeah. Everybody with tricuspid valve regurgitation?
Yeah, I guess it depends on how aggressive you want to be. But in my opinion, I think anyone with more than moderate TR, oftentimes it's underestimated by transthoracic echo. And so if they have greater than moderate TR and symptoms that are limiting enough to warrant an intervention, I know that's a little bit vague. I think that tends to mean, does the patient want something done, A, and B, is it someone who's in and out of the hospital all the time with volume overload and anasarca and needing all this diuresis? Those are clearly people that would benefit from this. Those that kind of have minimal symptoms and maybe aren't in the hospital too much, they're on minimal meds, I think most people would be able to identify, that's not someone who you're really going to get a lot of benefit from this. So it's primarily symptomatic, and then those that are in the hospital a lot.
Yeah. So would you like to see a TE before you do or surface echoes enough?
Again, that's a little bit specific to the institution. In general, we'd rather have them not have a TE. It's fine just to send them with the transthoracic, and then we will do the TE. And the reason for that is we specifically shunt these patients to getting their pre-imaging TEs with the same imagers that are in the room with us when we do the procedures. And that just really helps with not only just the speed of the study, just because they know exactly where to go for all the images that we need, but also the measurements and sort of the workup. It just sort of streamlines things a bit. And so I wouldn't say it's bad necessarily to do a TE ahead of time, but if you are doing that, it may be worthwhile to talk to one of the interventional imagers that can sort of guide you on which angles and images that would be useful for the workup.
Yeah. And once the patient comes in, you evaluate in the heart team, and the surgeon will see like a TAVR, evaluate the patient too?
Yes, exactly. We're doing that right now. The guidelines are sort of in the works, but the surgeons have been very involved, and I do think it's useful to get their input. Sort of like we talked about earlier, there aren't very many patients that are ever going for surgery, but it's always useful just to kind of bounce it off someone that has an alternative therapy.
Right. Comments on the procedure itself now. Let's move to almost the final segment is the procedure itself. This is a TE guided procedure, correct?
Yes, there is a little bit of fluoroscopy, obviously, but mostly it's driven by TE. And then I know we'll probably get to this, but more and more we're using intracardiac echo as well.
Okay. And this is to help you identify gripping as well as the best angle, or can you walk us through like what you as interventional cardiologists look for when you are seeing a TE?
Yeah, yep. So on the TE, number one, it's sort of being able to do the measurements. How big is the valve? You don't tend to run into issues with tricuspid stenosis with these cases where that's much bigger of an issue with mitral interventions, particularly with MitraClip or Pascal. But the tricuspid valve is so large that it's rare. It does happen, but it's very uncommon. And so being able to do the valve area measurements, the coaptation gap in particular for the clips is very important. There's many cases where the valve is so dilated that it's just too much of a gap to think about putting a clip on there. There are ways around that. We call it zip-in clip, where you sort of start near the commissure where the leaflets may be more closely opposed, and you can sort of start there, you put a clip there, then that'll bring the leaflets a little more closer together, more towards the central part of the valve. In general, I don't love doing that unless if there's a lot of TR in the area of the commissure anyway, and they might need a clip, then that's great. But if there is a large coaptation gap, that will tend to shunt you towards considering an evoke or a valve instead of a repair device.
Sorry, I asked you this question before, but I'll ask it again. You always clip the same leaflet, or it depends on the etiology? Because the septal leaflet is like literally hanging by a septum. So septum. So you always clip the other leaflet, or what's your approach?
Yeah, I'd say 99% of the time you're clipping something to the septal. It's either the anterior or the posterior, just depends on wherever the TR is. Very rarely would you do an isolated anterior posterior clip. That's just because you don't get the anchoring to the rest of the myocardium over there.
Right. Okay, so we spoke about imaging and TEE. So the imager is very important, and we have multiple guests before talk about invasive imaging and structural imaging, that they require some dedicated, sometimes training, like a 1 or a year of dedicated training. So is it the same thing in the institution, or this is somebody who got godfathered into practice and was able to give you the images that you want?
We have a mix of both. So some of our more recent hires have done a dedicated structural heart imaging year. And I do think that really helps, particularly if they came from an institution that does a lot of tricuspid interventions, and so they know exactly what to do for it. That said, we do have some of our imagers that also were sort of grandfathered and learned it themselves. Either way, I think, is just fine. That said, some of our imagers enjoy these procedures and some don't. So it's always nice to do them with the ones that enjoy doing the tricuspid interventions. But more and more, I think there's a massive need for structural imagers. And so if it's a field that someone's interested in, you could almost get a job anywhere if you have good training. So I definitely recommend the structural imaging fellowships, and they're still not standardized. They're not part of ACGME yet. I don't know if they ever will be, but the ones that exist are all very good. So,
yeah. So again, for the fellows on the call, or the people who are watching us, this is like a great segue if we're interested in imaging. Focus on that. Now, speaking of imaging, as the last segment is, which is the feature of the talk, is about ICE, intracardiac echocardiography, and how you can use it, and is it feasible to use it in these procedures?
yeah, so we could talk about a whole hour about this, or if not longer. So the rise of three-dimensional ice has kind of driven this. 2D ice is also used, but it does add a bit of a nice component if you have the 3D capability. It's been primarily, I'd say, used for left atrial appendage work, but more and more it's starting to be used in the tricuspid space. It just really assists with being able to, number one, just evaluate the valve. We've had some cases where even with their pre-op imaging, we couldn't get good pictures on the TE. And so we would just bring them to the cath lab for a right heart, and then we would put an ICE probe up and do all of our pre-imaging with the ICE probe. Additionally, then, most of our tricuspid procedures, I wouldn't say all of them, but most, we will do concomitant TEE and 3D ICE imaging. We have done a few cases with just ICE, so it is doable to do it alone with that, but we find it most useful to have both. The nice thing about the ICE is you can get very close to the valve. So even in these patients that have very large right atrium because of the years of tricuspid regurgitation, there's a way to retroflex the ICE probe so you can get it closer to the valve than you could ever get with a TE probe. And that allows you not only just to kind of see the baseline images, but making sure that you're getting a good grasp with the leaflets inside of the grippers, making sure that you get a nice grab of both the leaflets once you sort of close the device, and then seeing the TR reduction. It's also really nice for looking at the hepatic veins. That's not that hard to see with other imaging modalities, but when you're coming right up next to the vein, you can see almost all these patients will have vein flow reversal when you start the procedure, and then afterwards there's almost always at least an improvement, if not a complete shift to forward flow.
To learn this, do you need a proctorship?
You don't. Anyone can do it. I would say the ICE learning curve is pretty steep. It's not something that we're super used to in the interventional world. Maybe if you do PFO work, that's really the only time that we tend to use it. I highly recommend getting a proctor just to get your feet wet and sort of get started with it. There's a lot of teaching courses where you can come and learn on animals. The tabletop demos are useful. It's obviously a lot different when you're using it on a patient, but that is probably the best way to learn how to use it. And then also, it's useful to have your imager learn it with you because most of the controls are still done by the imager. And so I think having a team that you're both interested in using ICE is probably the best way to succeed in this area.
Okay. The first cases, do you recommend doing both TE and ICE together? At least you are familiar with the anatomy, or you can just go with ICE alone?
Yeah, I definitely would not start with just ICE. If anything, I'd say get comfortable doing tricuspid work with just TE first, and then add in your ICE imaging. You can use it as much or as little as you need since you have your TE probe there. In general, I don't really see the need to get to an ICE only based procedure quite yet. I think maybe in the future we can get there, but the procedure tends to be like a 2 hour, I'd say on average 2 hours long, and so that's a long time to have a patient with a TE probe down if they're only under conscious sedation. I guess you could argue that maybe that would be a reason to try ICE, but Concomitant, I think, is probably the way to go. The downside to that is you can't bill for both right now. And so you end up eating the cost of, generally, it's usually the ICE probe. But that's sort of a larger topic for discussion about imager reimbursement, because the amount of time that they spend doing these transcatheter procedures with us generally isn't reimbursed as well.
Is ICE reimbursed for this procedure?
It can be, but then you can't bill for the TE part of it. So
yeah. If it's ICE only, you can, but both, somebody has to cancel, right? One.
Yeah, so that's an area that I think, I don't know if like the ASE Society is sort of working on that part of things, but it'd be a good future maybe topic for your podcast here, is to bring an imager on and talk about reimbursement for structural.
Right, or protected time, or time to work, or something, or different than RVU. Yeah. Exactly. So it's, when I stay in ICE, I know we're talking about tricuspid, but is the ICE used in other structural intervention in your practice?
Yeah. So we use it for our LAA procedures. I also have used it for PFOs, ASDs. That's very useful in those cases. Those tend to be pretty quick, and you can get really good images because you're right next to the septum. Some sort of interesting uses. There was a case I did with a large pseudoaneurysm in the aorta that stemmed from a prior CABG, and so there were all these little holes where the grafts used to be, and we just really could not get good pictures of it. And so it's off-label, but we put the ICE probe in the aorta directly, and we're able to visualize the os to the pseudoaneurysm. And that was just published maybe a month ago. So lots of kind of cool things that are windows that are being opened by using ICE, where before you just kind of have to struggle.
You mentioned 3D ICE and 2D ICE. What is the difference, and what you can use one versus the other?
Yeah, so things like PFOs, ASDs, you don't tend to really need 3D in those cases, and so in general we use 2D for that. The nice thing about 3D ICE probes is that they're reusable, and so you can clean them and use them again. Right now, the 3D ICE probes are not, and so that does add a significant expense to the procedure. 3D is particularly useful in both LAA and tricuspid, just because it is sometimes difficult to get things in view. And so when you have a nice 3D image, you can sort of reconstruct whatever view you need from the 3D image, as opposed to having to struggle and fight with going to multiple angles and trying to get your device in view with the 2D probe. So in general, the more complex procedures, we do tend to use 3D, but I'm still using 2D for all my PFOs.
There was concern from a TE probe to get heated. The longer you use it, the more temperature. Is it a concern also from the ICE? Does the catheter get hot?
Nope, that's not a problem at all with the ICE probe. Since it's such a much smaller probe, the heating is not a problem with it.
Yeah. I'm not going to be talking about brands, but is there any specific brand that you recommended for tricuspid versus PFO versus LAA?
Yeah, so this is a long discussion that we could have as well. There's pros and cons to each. There's three main devices. There's a Siemens, there's a Philips, and there's one made by New Vision that is sort of it's Biosense Webster or Johnson & Johnson. I've used all three. They all have their areas where they shine. In general, right now, I would say the quality is best on the Philips system. It's also nice because the 3D ICE probe for Philips plugs into the exact same echo machine that you use for transthoracic and transesophageal echoes. So instead of having to have multiple machines in the, just kind of flip between the TE and the ICE probe while you have both of them down with Philips. The other two right now have their own dedicated systems, but I know for Siemens, their next gen ICE probe will connect to their TE machine. The Biosense Webster has its own system in general. So there's a lot of attention being focused on this by the companies, and so big updates that are coming. I see it as a very fast moving area with the image quality. It's at the point where a lot of cases you couldn't, if I asked you to say, is this a TE or an ICE image, you wouldn't be able to tell the difference.
Dr. Schwartz, again, it's been a pleasure talking to you. Is there anything or any question I missed to ask you about this topic, whether tricuspid valve or imaging of the tricuspid valve?
Oh, I mean, as you can tell, I'm very passionate about this, so we could have talked for probably another hour. The only thing I would say is, despite being a clip and a valve that are now approved and being used, the Evoke and the TriClip device, I think Pascal is close behind. That should be out maybe later this year. It might be another couple of years before it's approved. But there's a lot of really interesting things that are under development. I know that's true of all structural heart, but sort of some different ways of deploying the valve are being studied. There's some valves that you can put in the inferior and the superior vena cava and just leaving the valve alone. And so I see this as a hot moving area. It's definitely going faster than mitral. And so I think pay attention because there's some cool stuff coming.
Okay, sounds good. Dr. Schwartz, again, it's always a pleasure seeing you in person. I think next our meeting going to be either Sky or CVI. I really a pleasure seeing you and learn a lot from you. You're a colleague, a friend, but definitely have been pushed this space and structural space is in a completely different dimension. You and your colleague and your friend in that space. I appreciate your time. For the audience, thank you so much for joining us, fellows, resident techs, nurses, cath lab, and well as vendors. Thanks for joining us, and thanks for FACET for putting this together. Join us next month. It's going to be, as always, third Thursday of the month at 6 p.m. Eastern Time. This is Heart Trending. Dr. Schwartz, thanks again for being with us.
My pleasure. Great to see you, Chad.